Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Volz. Last episode, we talked about how medicine develops blind spots, how a good idea, or sometimes a weak idea, can get locked into guidelines, training, and professional identity in a way that makes it unusually hard to update. We talked about appendicitis, we talked about peanut allergies, and we talked about a bigger pattern. Medicine is full of smart people, but smart systems can still get stuck. Today, I want to go deeper on one blind spot that hits families very directly, especially parents of young children. It's antibiotics. More specifically, it's what happens when one of the greatest tools in medical history becomes overused, normalized, and handed out in situations where the benefit is small, uncertain, or non-existent. And I want to say this clearly at the start. This is not an anti-antibiotic episode. Antibiotics are one of the great miracles of modern medicine. They save lives. They have saved millions of lives. If you have bacterial meningitis, sepsis, a worsening pneumonia, or a serious skin infection, you want antibiotics fast. No hesitation. So this is not a story about rejecting medicine. It's a story about using a powerful tool with more care. Marty Makary uses a phrase that sticks with people. He says, unnecessary antibiotic use can be like carpet bombing the microbiome. And once you understand what the microbiome actually is, that metaphor lands differently. Inside your body, especially in your gut, you live with a huge community of microorganisms, bacteria, fungi, and other microbes that are not just random passengers. They help digest food, they help train the immune system, they help resist invading pathogens, they appear to influence inflammation, metabolism, and potentially even signaling along the gut-brain axis. In other words, they are not just along for the ride. They are part of the operating environment your body depends on. In early life, that microbial environment is still being built. The first couple of years matter a lot. You can think of that period as the foundation phase. The body is not just growing bones and organs, it is also establishing patterns, immune patterns, inflammatory patterns, microbial patterns that may shape health for years. That does not mean every disruption causes permanent damage. We should be careful not to overstate this. But it does mean early disruption is not trivial. And antibiotics, by design, are disruptive. They do not neatly remove one bad actor and leave the rest of the ecosystem untouched. Even when they are absolutely warranted, they often affect a broader range of bacteria than the one causing the infection. That trade-off is sometimes worth it. Sometimes it's life-saving. But it is still a trade-off. Makary points to data suggesting that American children receive antibiotics very frequently in early life. The exact number can vary depending on the source and the population studied, but the big picture is not controversial. A lot of children get a lot of antibiotic exposure, especially for respiratory and ear-related complaints. The concern is not just short-term side effects like diarrhea, rash, or yeast overgrowth. The deeper concern is whether repeated exposure in early childhood may increase the risk of later problems such as asthma, obesity, allergy-related disease, or other chronic conditions. This is where the evidence gets important and where careful wording matters. There are observational studies that show associations between early antibiotic exposure and a higher risk of several later childhood conditions. One widely discussed Mayo Clinic analysis looked at a large pediatric data set and found that children exposed to antibiotics early in life were more likely, on average, to later carry diagnoses like asthma, obesity, attention-related disorders, and celiac disease. That gets attention fast, and it should. But we also need to be honest about what those studies can and cannot prove. Observational research can show correlation. It cannot, by itself, prove causation. A child who gets more antibiotics may also be a child who had more infections, more medical contact, different feeding patterns, different environmental exposures, or other confounding factors. So the responsible conclusion is not antibiotics definitely caused all of those outcomes. The responsible conclusion is narrower. There is enough signal here across multiple studies, enough biological plausibility, and enough concern from pediatric and microbiome researchers that unnecessary antibiotic exposure should be taken more seriously than it often is. That is a fair conclusion. And there is another reason the concern is credible. Some studies suggest a dose-response pattern. In plain English, more antibiotic exposure appears to track with more risk. That does not settle the causation question, but it makes the signal harder to dismiss casually. The problem is not antibiotics. The problem is unnecessary antibiotics. This is the distinction I want parents in Southern Oregon to hold on to. Necessary antibiotics are good medicine. Unnecessary antibiotics are not neutral. If a child has a viral illness, an antibiotic is not a harmless just-in-case move. It does not help the virus. It does expose the child to side effects. It does contribute to resistance. And it may disrupt the microbiome without a meaningful clinical upside. That is why stewardship matters. And stewardship is just a fancy term for using antibiotics when they are likely to help, and not using them when they are unlikely to help. That sounds obvious. In real life, it gets messy. A parent has taken time off work. The child has been sick for days. Everyone is tired. It is hard to get a same-day visit in primary care. Urgent care is packed. The clinician has 10 minutes. The family wants relief. The provider wants to be safe and wants the visit to end with the family feeling helped. In that environment, prescribing can become the path of least resistance, not because clinicians are bad, because the system is built for speed, liability management, and throughput. That is the system story here. This episode would still matter anywhere in the country, but it matters in a specific way here. In Jackson County and Josephine County, a lot of families are navigating tight access. Same-day pediatric access is not always easy. Primary care is strained. Urgent care often becomes the default release valve for everything from ear pain to sore throats to lingering coughs. And urgent care settings nationally have often shown higher rates of inappropriate antibiotic prescribing than we would like to see. That does not mean every urgent care in the Rogue Valley is overprescribing. It means the structural conditions that can lead to overprescribing are very much present here. Short visits, limited follow-up, parent pressure, uncertainty, a desire to do something. When you combine those conditions with outdated expectations, like the old assumption that every ear infection needs an antibiotic right away, you get a lot of unnecessary exposure. And then there is a second Southern Oregon issue. When communities have less access margin, outdated habits can linger longer. If national guidance changes, but local patients are still cycling through rushed visits and fragmented care, the updated nuance does not always travel well. That is how blind spots survive in real communities. A lot of parents understandably assume that if a child is sick enough to be seen, a prescription is probably the point of the visit. But many of the most common childhood illnesses are viral. Colds are viral. Most flu-like illnesses are viral. A lot of sore throats are viral, though strep is a real exception that may justify testing and treatment. Many sinus and ear complaints improve without antibiotics, depending on the child's age, severity, exam findings, and how long symptoms have lasted. That does not mean never treat. It means not every red ear, every fever, or every bad week needs an antibiotic. Sometimes what a child really needs is time, fluids, fever support, monitoring, and clearer guidance on when to come back. That may feel less satisfying in the moment, but sometimes it is the better decision. Makery also makes a broader point that I think is useful. He describes how prophylactic antibiotics, meaning antibiotics given to prevent infection rather than treat an active one, became standard in surgery. For higher risk procedures, that practice has real evidence behind it and real value. But over time, the logic spread. What began as a targeted evidence-based practice became a near universal routine in some settings, even when the infection risk in a given procedure was very low. That example matters because it shows the pattern. A tool proves useful in one context. Then it becomes a reflex in many contexts. Then the reflex becomes protocol. Then the protocol stops feeling like a choice. That is what blind spots look like in medicine. Not dramatic corruption most of the time, just habit hardening into dogma. There is another reason antibiotic overuse matters, and this one is not theoretical. The more we use antibiotics, especially when we use them broadly and unnecessarily, the more evolutionary pressure we place on bacteria to adapt. That is how resistance develops. And antibiotic resistance is not a niche academic problem. It is already a major public health problem. The exact annual death count depends on the methodology and whether we're talking about direct deaths versus associated deaths, but the core fact is solid. Resistant infections kill a lot of people and make many more infections harder to treat. So there are really two overlapping risks. One is the individual level risk of unnecessary exposure, side effects, and possible downstream microbiome disruption. The other is the community level risk that we keep weakening one of the most important treatment tools medicine has. That is why stewardship is not just a personal preference, it is a public good. Now let's make this practical. If your child is sick and a clinician is considering antibiotics, you do not need to become combative, suspicious, or pseudo-expert. You just need better questions. Here are 5 useful ones. 1. Do you think this is more likely viral or bacterial? That question gets right to the core issue. If the clinician says viral, the follow-up is obvious. Then what benefit are we expecting from an antibiotic? 2. What findings make you think antibiotics are warranted here? You are not asking them to defend their degree. You are asking what specific evidence in this case supports the decision. Is it the exam, the duration, the fever pattern, the strep test, the ear exam, the child's age, worsening after initial improvement? That helps separate a reasoned prescription from a reflexive one. 3. Is watchful waiting reasonable here? This matters especially for selected ear infections, sinus symptoms, and some mild respiratory presentations. Watchful waiting does not mean neglect. It means you monitor carefully, use supportive care, and start treatment only if the child is not improving or is getting worse. Sometimes a clinician will even give a delayed prescription, meaning you leave with the prescription, but use it only if certain changes happen over the next day or two. That can be a smart middle ground option. 4. What should I watch for that would make antibiotics clearly necessary? This is one of the best questions in healthcare in general. What would change the recommendation? If the fever lasts, how long? If breathing changes, in what way? If the pain worsens, by how much? If there is drainage, lethargy, dehydration, or a positive test. You want the update triggers. 5. What is the downside of waiting 24 to 48 hours in this case? Sometimes the downside is too high, and the answer is we should treat now. Good. Then treat now. But sometimes the honest answer is the downside is low, and the likely outcome is that this improves on its own. That is useful information. I also do not want to leave this too abstract. There are situations where the balance shifts quickly and where a cautious wait-and-see posture may be the wrong move. A child who is struggling to breathe. A baby who is unusually lethargic or hard to wake. A child who cannot keep fluids down and looks dehydrated. A rapidly spreading skin infection. A child with a very high fever who looks toxic, meaning they look genuinely very ill, not just miserable. Those are not moments for podcast philosophy. Those are moments for timely medical evaluation. And even in less dramatic situations, there are times when bacterial infection is more strongly supported and antibiotics are much more likely to be worth it. A confirmed case of strep. A pneumonia picture that fits clinically. A significant ear infection in the right age group with the right exam findings. A urinary tract infection. The point is not to turn every parent into a diagnostician. The point is to help families distinguish between we should ask better questions here and we should probably move. I want to be careful here because this topic can push people toward bad extremes. Do not hear this and decide that antibiotics are basically poison. Do not hear this and try to white-knuckle a clearly worsening bacterial infection at home. Do not hear this and assume one necessary prescription has ruined your child's long-term health. That is not what the evidence supports, and it is not what I am saying. The real point is simpler. Antibiotics deserve respect. Because they are powerful, not because they are evil. And powerful things should be used deliberately. A lot of parents may hear this and immediately think, my kid has already had multiple rounds. Now what? First, do not panic. Most parents made decisions with the information, access, and medical guidance they had at the time. Second, zoom out and think strategically. If your child has had repeated antibiotic exposure, especially in early life, this may be a reason to be more thoughtful going forward. It may also be a reason to pay closer attention to the basics that support resilience. Diet quality, sleep, outdoor time, reasonable infection prevention habits, and continuity with a primary care clinician who knows your child's pattern. If your child is dealing with chronic gut issues, recurrent infections, eczema, asthma, or other inflammatory problems, that does not prove antibiotics are the cause. But it may justify a more thorough conversation about the whole picture rather than treating each issue in isolation. That is one place where better longitudinal care matters. At the systems level, there are a few obvious improvements. 1. Stronger antibiotic stewardship programs across clinics and urgent care settings. That means feedback to prescribers, decision support, shared protocols, and accountability around prescribing patterns. 2. Better patient education. Families should not have to learn the difference between viral and bacterial illness from random social media clips. Clinics can explain this better, in plain language, before the next sick visit ever happens. Handouts, portal messages, after-visit summaries, and school-facing education could all do more work here. 3. Better access to follow-up. A lot of unnecessary prescribing is really an access problem, If a family knows they can check in tomorrow, waiting feels safer. If they think this is their only shot at care for the week, pressure to prescribe goes up. 4. A stronger culture of shared decision making. Not every visit has to be paternalistic. Parents can handle nuance if we give it to them clearly. And in Southern Oregon, where trust in institutions is uneven and access is tight, that kind of transparency matters even more. The antibiotic story is not just about medication. It is about what happens when a life-saving intervention becomes so culturally established that we stop recalculating the trade-offs. That is the blind spot. The assumption that because something works powerfully in one context, more of it must be safer than less. But medicine does not work that way. Dose matters, timing matters, context matters, age matters, risk matters. And in this case, the early childhood context may matter a great deal. If you remember one thing from this episode, let it be this. When antibiotics are clearly needed, they are a gift. When they are not clearly needed, asking better questions is not anti-medicine. It is good medicine. That is the posture I want more families in the Rogue Valley to have. Not cynical, not passive, calm, informed, and willing to ask, what problem are we treating, and how sure are we? Those questions protect your child. They also protect the future usefulness of antibiotics for everyone else. If this kind of analysis helps you think more clearly about healthcare decisions, subscribe to the newsletter at reimagine-healthcare.org. If you know a parent, pediatric clinician, teacher, school nurse, or urgent care provider who would care about this conversation, send them this episode. Because better local healthcare culture does not come from one podcast episode. Next time, we'll zoom out again and look at the training culture underneath many of these blind spots. How medical education can reward memorization, compliance, and protocol following more than curiosity and adaptive reasoning. This podcast is for educational purposes only and does not constitute medical advice. If your child is seriously ill, worsening, or showing red flag symptoms, seek medical care promptly. And if you hear an error or think I missed something important, reach out. Thoughtful dialogue is part of how better healthcare gets built. Thanks for listening.